Managing penetrating back and flank injuries. Let's dive into the key takeaways. Hey everyone, welcome back to the channel. Today, we're diving into something a bit more clinical. The latest evidence-based tips from the Eastern Association for the Surgery of Trauma, or EAST, on managing penetrating injuries to the back and flank. This is important stuff, so let's break it down. Setting the scene. What counts as the back and flank? So first off, let's get our bearings. In medical terms, the flank is the area between the front and back sides, running from the sixth rib down to the hip bone. The back is basically what's behind your spinal muscles. Pretty straightforward, right? First steps. What to do when a patient arrives if someone comes in and their vital signs are all over the place. Unstable. In other words, it's go time for surgery. No questions asked. But if they're stable, you've got a little more room to investigate with some imaging and careful examination. Imaging. The power of CT scans for stable patients. A CT scan with IV contrast is your best friend. If you think there might be injury to the hollow organs, you can add oral contrast too. It's super sensitive for catching those tricky retroperitoneal and intra-abdominal injuries. Some folks suggest triple contrast CT, but honestly, IV only is usually enough for most cases. When you can skip surgery, non-operative management. Let's talk about managing these injuries without going straight to the OR. If the patient's stable, shows no signs of peritonitis or internal organ injury, and their CT scan looks good, no free air, no active bleeding, you might be able to manage them without surgery. But, and it's a big but, you've got to keep checking them with serial abdominal exams. When you can't avoid the OR now, if the patient's unstable, you see signs of peritonitis, or their CT scan shows something serious, like bowel perforation or active hemorrhage, they need surgery right away. No time to wait. Special cases to watch out for. Diaphragm. Left-sided injuries around the thoraco-abdominal area are risky for diaphragm injury. If the CT doesn't give you a clear answer, laparoscopy or thoracoscopy can help. Kidneys. Most kidney injuries can be watched unless there's major bleeding or the blood supply is compromised. Colon. Any colonic injuries? They'll need antibiotics. Think ceftriaxone and metronidazole, and probably some surgical repair. What about antibiotics? For superficial wounds that don't go into the belly, you don't need to hand out antibiotics like candy. But if you're heading into surgery, make sure you're covering both aerobic and anaerobic bacteria. Big picture. What should you remember? If your patient's stable, CT is king for evaluation. If they're unstable, don't wait. Take them to surgery. Non-operative management can be safe, but you've got to monitor closely, and always pay extra attention to injuries of the diaphragm, kidneys, and colon. That's our deep dive for today. If you found this breakdown helpful, don't forget to like, subscribe, and hit the bell for more medical insights. Stay curious, stay safe, and see you next time on the Everything Surgery podcast. Dissect the extraordinary.